Okay. Great. Hi, everybody. My name is Lauren Boal, and I'm a pediatric hematologist oncologist at Mass General Brigham for Children. We just changed our name. And I'm going to be talking about neurologic screening in children with sickle cell disease. I will also be followed by Dr. Cheryl Azar, who is also from Mass General, and will review some of the adult care that is similar, but with some differences in how we manage screening for sickle cell disease in the brain. So there's a few things that I'm going to be talking about today, are screening children with sickle cell disease for developing ischemic strokes. As you just learned, ischemic strokes are our biggest issue in the pediatric population. And I'll be going over transcranial Dopplers and how we use those to screen for ischemic strokes in those patients who could benefit from changes in their treatment. I'll also go over a bit about MRI and MRA evaluations of the brain to look for silent cerebral infarcts and abnormal blood vessels, and also very briefly about screening children for what's called retinopathy with eye exams. We'll start with who should get routine screening for strokes in children. I know we just went over this, but a stroke happens when blood doesn't flow to the right place in the brain that it's expecting to, and it can cause damage to brain tissue. And it's because these red blood cells in sickle cell, they're hard, they're sticky, they're shaped like a banana, and they can block these blood vessels, leading to a stroke. That risk in children has been shown to be highest in two types of sickle cell disease. One is hemoglobin SS, and one is hemoglobin S beta 0 thal. Thalassemia. If you're not sure what kind of sickle cell disease you have, definitely talk to your hematologist. They do know, and they can explain to you what your risks are. So in these patients with these two types of sickle cell disease, we do recommend the transcranial Doppler screening that was just mentioned. That's so for children who are 2 to 16 years old. We yearly check an ultrasound or a transcranial Doppler to find out which patients with those types of sickle cell are at highest risk of developing a stroke, because we may need to change their treatment. Other children with other types of forms of sickle cell disease do not need routine screening unless your hematologist talks to you for some other reason to evaluate, but otherwise it's not going to be a routine part of your care. Another plug for hydroxyurea, we'll probably talk about it a million times today. It is a wonderful medicine for those it's indicated for, and can decrease your child's risk of developing an ischemic stroke. So please talk to your doctor or NP if you have not. So what is a transcranial Doppler? So I stole these pictures from the internet, I think at Nationwide Children's, so a real place. And here's a child getting a transcranial Doppler up on the right, and a technologist working on it on the bottom. So this is a really great test because it is painless. It's non-invasive, it doesn't require a poke, and it doesn't require sedation. So as you may know, in sickle cell disease, sedation and anesthesia for certain kinds of tests that we sometimes have to do in kids. Sedation carries its own risks and is more complicated in kids with sickle cell than kids who don't have sickle cell. So this is something we can do in an outpatient radiology center in your home hospital, I'm sure, where the technologist meets with you. They put a gooey gel, kind of like if you have an ultrasound when you're pregnant, and put that on the head. And this small device that you see up there on the right, a little probe, is moved around on the head to find the blood vessels that we are trying to evaluate. And that we measure the blood flow and how fast the blood is flowing through those blood vessels. And the numbers we're able to report helps us decide what we need to do. Of course, in all tests, the easiest and best results come when somebody is not moving around or flipping upside down the way that children sometimes want to do. So there are some situations where we're not able to get all the numbers that we want to get, and we'll require a repeat test. These are all children getting these tests, so we're aware of that and can manage it. And as I said earlier, no sedation. So your child can eat, your child can drink, you can come in and out of the appointment, and the length of time probably depends on your technologist and your child, but it's not too long of a test. And just to say, there are some other forms of these transcranial Dopplers that are done in some centers that may have different interpretation of results. So what do we do with these results? When I was in training, the first time I looked at one of these transcranial Doppler reports, it looked very overwhelming. There are lots of numbers, lots of letters. So just kind of to boil it down into the most important features, if the blood speed is faster than we want it to be, that shows that there could be a higher risk of a stroke for your child. And that's because if there's a narrowed blood vessel, blood is trying to shoot through that blood vessel faster, it can represent that we may have an incoming blockage of the blood vessel in the future. And there are 3 different report summaries that I would say. We either have a normal result, an abnormal result, or something in between that we call conditional. You do not necessarily need to take these numbers home with you as something to remember. That is your provider's job to tell you what these mean. But normal is generally considered less than 170. And if you have a normal result, you will continue on your yearly evaluation with a transcranial Doppler that we really encourage you to stay on top of, because we want to catch things before they get to the abnormal stage as they progress towards abnormal if they're doing so. So that leads me to the conditional TCD result, which is the borderline result. So it's not quite the number that we would change your therapy for, but we need to watch you more closely. And the exact frequency at which your doctor or NP or provider would check you again depends on exactly what that number is. If you're right at the edge of being in the abnormal range, they'll probably check you sooner than if you're barely into the borderline range. So every couple months is often how often, if a conditional TCD is found, that you need to be checked. And again, if you're not on hydroxyurea, this would be a great opportunity to start it, because you may be able to help prevent this from getting to this abnormal stage. So an abnormal TCD is when your blood flow is more than 200. And in that case, if we're able to confirm that that's truly real by repeating a test in a couple weeks, and your provider will tell you how soon, then we usually recommend starting therapy to prevent a stroke, because your child or you are at higher risk of developing a stroke than other kids with the same condition. And that usually would be with chronic transfusions, which we will talk about, or somebody else will talk about later this morning. And often you would also have an MRI evaluation of the brain as well to see whether you've developed those silent strokes that were talked about, and possibly also for what's called an MRA, which looks at the blood vessels of the brain to see whether there are any abnormalities in the blood vessels to explain these changes. So TCD is very important. Please go to your appointments to get that checked out. And then moving kind of from our ischemic stroke evaluation, which is kind of the information on the left, and we already went over signs of a stroke and emergency calling 911 if you're worried. But the silent cerebral infarcts, or silent strokes, that sometimes we don't know are happening at all, but we know are really common in sickle cell disease, even in children. And that's from blockages of smaller blood vessels over time, and you usually often don't have any physical symptoms like numbness or vision changes, things like that, but you can have changes in learning, changes in memory, and it can signal that you may be at a higher risk of developing a stroke down the line. So then how do we look at those, and whether they're there or whether you have a risk of them? Again, the patients who are at highest risk are those with hemoglobin SS disease and hemoglobin S beta 0 thalassemia. So in those patients, the American Society for Hematology, where we get a lot of our guidelines from, they recommend doing a one-time screening of the brain at what they call early school age, which is a very vague term, but the point is that they want children to be able to sit still to have this test done. And as anyone who's a parent or knows any children, they do not sit still at all until, I don't know, 8, 9, 7. It really depends on what child you have. You know your kid best, and work with your doctor and be about when you actually think they will sit through an MRI. And if you've been through an MRI, it's loud, it's a big tube, it's unsettling. My husband, he's not here, so we won't know. He can't handle an MRI without medicine. So it's really dependent on your child when this actually gets done, because we want to do it just once, because sedation in children with sickle cell disease carries risks. So we don't want to do that beforehand unless we need to evaluate the brain urgently, and then we'll do it in the safest way we can. And then just to say, if you don't have hemoglobin SS disease or hemoglobin S beta 0 thalassemia, that doesn't mean your doctor will never recommend getting imaging of your brain. You may also, if you have learning challenges, developmental challenges, educational challenges, or neurologic symptoms, you may also get these evaluations. And then MRA screening is not technically in the recommendations, but it's often done. And that's a test that you can do at the same time as your MRI that looks at the blood vessels, how they're shaped, and can find those things that we were showing in the last presentation, like aneurysms and Moyamoya syndrome, that may need somebody to do an important thing like a surgery to correct, to prevent your risk of developing neurologic conditions or things like strokes. And you may need to be evaluated by a neurologist or a neurosurgeon, but your whole multidisciplinary team would help you make decisions in that case. And then lastly, the eye. So another issue you can have related to blocked blood vessels is you can develop something called retinopathy, which is caused by blockage of blood vessels that supply the retina, which, as you see from this other diagram, is at the back of the eye. And if you develop damage to the retina, you can get a lot of really concerning symptoms like vision loss and even blindness in severe cases. But earlier symptoms, you can have dark spots, you can have blurry vision. So if you're noticing vision changes of any sort, you should tell your provider. There certainly can be non-sickle cell and blood vessel related reasons to cause some of these symptoms, but we want to be really careful if you're having any of that. The patients at highest risk have actually hemoglobin SC disease compared to the other neurologic issues we were talking about. And it often takes time. It's not something that 2 or 3 years old we usually screen for. And also 2 or 3 year olds don't tolerate eye exams very well. So starting at 10 years old and into adulthood, we start annual screening with a dilated eye exam. I find this to be one of the hardest things for my patients to be able to adhere to and get scheduled, because you have to get that appointment. It's not at your primary hematologist's office, but a dilated eye exam with drops where they can really look at the back of the eye is how we screen for retinopathy. So just some take-home points for the pediatric part of this. Children with sickle cell disease with these 2 forms of sickle cell disease are at the highest risk of ischemic strokes and silent cerebral infarcts. And we recommend screening with TCDs for children 2 to 16, and MRI with maybe an MRA when they're school-aged and can sit without sedation. You may, if there are abnormalities in either of these, you may need therapy to prevent a stroke, and a plug for hydroxyurea to prevent us from getting to a point where a stroke happens. And then annual screening for retinopathy is needed starting at 10 years old with a dilated eye exam. And that's it.